Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is Behçet's disease, part of our Rheumatology and Vasculitis series. So what is Behçet's disease? This is a condition which can affect all size of vessels, so it's known as a variable vessel vasculitis as per the Chapel Hill classification, which you might remember from the first lecture of the vasculitis series. It's a multi-system inflammatory disorder of unknown etiology. The disease most commonly affects people from the Mediterranean and Middle Eastern populations and usually starts in the 30s or 40s. It equally affects males and females. Regarding signs and symptoms, these can be really quite wide-ranging, affecting multiple organ systems. So it's really important to take a thorough history and perform a thorough examination as well. So the first symptom to ask about is a history of painful oral aphthous ulcers, as well as genital ulcerations. Particularly from a PACER's viewpoint, this can be quite a taboo subject in the clinic setting, so it's really important to take a good and sensitive history here. Patients may often report many months or longer of genital ulcerations, for example, which have given negative swab results on microbiology testing. And with regards to their aphthous ulcers, these are usually recurrent and quite painful. It should be noted that idiopathic oral aphthous ulcers are quite common in the general population, and does not of course mean that one has a diagnosis of Behçet's. Secondly, looking at the skin, there can be quite wide-ranging rashes. So these can include vasculitic rashes, nodular rashes, and rashes that mimic acne. So we call these an acneiform rash. One of the specific things which is seen in Behçet's is something known as pathogy. And this is hyperreactivity of skin to a needle prick, as you can see in the picture. So the skin in the picture has been pricked with a sharp needle and then left, and this reddish kind of surrounding area has now formed. Pathogy is also seen in a couple of other conditions, including Sweet syndrome and inflammatory bowel disease, but it's quite a useful test to conduct if looking for Behçet's syndrome. Ocular symptoms are characterised by the presence of recurrent panuveitis, which is the most common ocular manifestation. Patients may also present with arthritis and arthralgia. With regards to cardiovascular and pulmonary involvement, this may present with thromboembolic manifestations, and in fact this may be the first sign that a patient has Behçet's disease. Examples include thrombophlebitis or pulmonary embolism. And finally, there are several neurological manifestations to be aware of. So many of these patients have headaches. Again, this is common in the general population, but patients with Behçet's will report headaches in many cases. And neuro-Behçet's may manifest with a variety of symptoms, including pyramidal symptoms, unilateral hemiparesis, behavioural changes, as well as aseptic meningitis. There are a variety of investigations which need to be undertaken in patients suspected to have Behçet's disease. So firstly, bedside tests include an oral and genital examination, as well as a full cardiovascular and gastrointestinal examination as well as looking at the joints and a neurological examination. Pathogy testing can be conducted in clinic, and ophthalmology review is really helpful as well to check for any signs of early uveitis. OBS should be conducted, particularly blood pressure as well as urine dip, because a differential diagnosis for these patients would be a small vessel vasculitis. Other investigations are similar to those we've discussed previously, so they include a full blood count, renal function, liver function, clotting screen and bone profile, as well as inflammatory markers which are CRP and ESR. The specific HLA subtype which is associated with Behçet's is HLA-B51, but the absence of it does not mean that a patient does not have Behçet's disease. And finally, it's important to conduct a full connective tissue disease and vasculitis screen in these patients with the tests we have discussed previously. Treatment can be wide-ranging and really depends on the manifestations and severity of disease. Colchicine is usually used first line in a lot of patients and is especially good for ulcers and skin. Steroids are also good rescue therapy and also may be used as well at the start of one's disease. Again, good for ulcers and skin. NSAIDs can be used for musculoskeletal involvement. DVTs and PEs require quite complex and higher level management. They can be treated with steroids and cyclophosphamide, but the use of anticoagulation is still an active area of research. In terms of disease-modifying therapies, azathioprine and mycophenolate may be useful in these patients, and later on it can be considered to start a TNF blocker as well. So let's do some questions. So the first question is, which of the following HLA subtypes is most closely associated with Behçet's disease? So your options are HLA-DR4, HLA-B27, HLA-B51, HLA-DR2, and HLA-B5801. So you'll remember from one of the previous slides that HLA-B51 is the correct answer here. And this is just something that is worth knowing about, particularly for the MCQ portions of MRCP. Second question, a 30-year-old Turkish lady presents to the rheumatology clinic with painful oral and genital ulcers of 3 months duration. Swabs with microbiology tests have been negative. She reports an acneiform rash since childhood, treated with topical preparations. Over the last month, she has noted worsening joint pains. A pathology test in clinic is positive. So given the likely diagnosis, which of the following treatments should be commenced? So if you were to see this particular vignette in amongst all of the MCQ questions in your part 1 or part 2 exam, Behçet's syndrome should be quite high in your list, just given the age, ethnicity, and all of these various clinical features she's presented with, as well as a positive pathology test as well. In terms of treatment, so if we just go through them, the first option is methotrexate, second is cyclophosphamide, there's low molecular weight heparin, colchicine, and roaccutane. So just working through these answers, methotrexate is not recommended in patients with Behçet's disease, so we can automatically disregard that. We think she's got Behçet's disease. We're pretty sure that she does. So roaccutane would not be the correct thing to give her in this situation, despite her history of acne, because we can see why she has that particular rash. It's because it's part of the Behçet's disease. There's no indication to give low molecular weight heparin here or cyclophosphamide, actually, because she's not presented with any sort of thromboembolic phenomenon, and her disease is not so severe that she requires massive levels of immunosuppression, as would be seen with cyclophosphamide. So the correct answer is the first line treatment for many patients, which is colchicine. So thank you for listening to this episode of Bite-Sized MRCP. If you like the sound of what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you'd like to hear from us in the future, and we'll see you in our next episode.